some housekeeping items to review. This CME activity is jointly provided by the Queen's Medical Center and the UH Jabsom Department of Geriatric Medicine. As a reminder, evaluations are required for CME. You will find the evaluation by following the link in the chat at the end of this talk, or in our email advertisement, or on our website. Your comments are very important to the planning committee and will be used to plan future programs. All speakers are asked about potential conflicts of interest, and these are usually disclosed on their slides. Today's speaker has no conflicts of interest with commercial enterprises in relation to the talk. It's my great pleasure to introduce Dr. Brett Liu. He is a geriatric psychiatrist who's been working in Hawaii since 2007. His professional interest focuses on evidence-based treatment of difficult-to-treat behavioral symptoms in medically complex and older patients. Currently, he provides psychiatry consultation in area hospitals and in several long-term facilities. He's also part of the collaborative care program at Queen's Medical Center, offering treatment suggestions for older patients seen in primary care settings. Please join me in welcoming Dr. Brett Liu.
All right, thank you, Kamal. So we're going to get started. So let me share screen. Okay, share. Okay. So can everybody see the screen or not really?
We don't see it yet, Brett.
Okay, well, I'm clicking on that window. Let me try one more time. You see it now? Okay, so let me start over. I'm sorry, I did a dry run earlier today. And so share and entire, I'm going to do entire screen share. Okay, okay, you got it, right? Okay.
It's coming. It's not yet there, but there we go.
Okay,
it's there.
Excellent.
Thank you, Brett.
Okay, all right, we can get it started. Sorry about that. Okay, so title of my talk today is Managing Cognitive and Behavioral Symptoms in Aging. It's a mouthful. You can cover pretty much everything. We can talk about these things for like days, if not weeks. But so what I'm going to do for the for today, I'm just going to focus on what the latest sort of evidence-based findings and treatment is. So more like an updates, as opposed to sort of exhaustive listing of everything that we could do. So these are the objectives listed for today, and I'm kind of going to be going backwards a little bit. So I'm going to start out by talking about how do we manage behavioral symptoms in dementia safely and effectively, and then followed by dealing with behavioral or settings, behavioral symptoms common in a primary care setting, specifically depression. And then toward the last bit of our talk, we're going to be going over sort of evidence-based modifiable factors that everybody can practice, things that we can easily engage our patients with, in how they can go about, in their everyday lives, looking at modifiable risk factors to lessen, cognitive and behavioral symptoms. Okay. So we're going to start from toward the end, which is, the bottom of this slide, which is dementia-related behavior. So dementia-related behavior, and for the rest of the talk today, when I say dementia, I usually would refer to Alzheimer's dementia, unless I make specific references to like Lewy body dementia or Parkinson's dementia. So this is kind of like a collection of various symptoms as definable clusters of treatment for dementia. And you've probably seen this many times, before in my talk before. And this includes psychosis, depression, agitation. Anxiety is often comorbid with depression. So what do we know about these? And I'm just going to go over very briefly what some of the more important ones are. And what's nice to, what we need to be aware is, most of these symptoms are reversible to a certain extent. So we don't want to be kind of waving the white flag that, well, they're dementia, this is it, this is just, there's no treatment. But no, there's a lot we could do to modify, the severity and the frequency of the symptoms. So if we start with psychosis, which is consisted of paranoid delusions and usually visual hallucinations, um, and specifically those with Lewy body dementia, predominantly presenting with very vivid visual hallucinations, followed by Parkinson's disease, dementia, and Alzheimer's. Um, and what we need to know about psychosis is not only can it lead to physical aggression, placement, also can increase mortality. So, and this is something that's reversible, especially knowing what physical aggression can be a huge stress, for caregivers in providing care for those with dementia. And depression in dementia is also, pretty common, 20% in those with Alzheimer's, compared to, say, general population, 5% of people in the general population would have clinical depression. So you see these numbers are much higher. And the highest would be in those with Parkinson's disease dementia. I would say, anxiety, depression, and Parkinson's disease dementia are some of the most challenging symptoms for us to treat. And so people with depression and dementia, they're not going to tell you they're depressed, but some of the telltale signs are they're irritable, they're making little effort to engage, or avoiding eye contact. So these are signs that you want to look for. And like psychosis, depression in dementia can also be associated with physical aggression, mortality, and faster memory decline. And this is a theme that you're going to be hearing about for the rest of my talk today is untreated depression, according to most studies, will lead to increased accelerated memory decline.
Oh, that's okay.
Okay. And the
John,
last
could you
cluster,
mute the
so
audience?
we're having a party here. Okay.
Thanks.
And the last symptom cluster we're going to talk about is agitation in dementia. And a lot more studies have been done looking at agitation as an outcome that could be modified with different type of medications. There are a lot of medication treatment in consideration to get that FDA approval for dementia-related behavior, and we're going to be going to that a little bit later too. So agitation globally kind of encompasses it's kind of impulsive, inappropriate behaviors, restlessness, kind of a lot of garden variety, verbal, physical aggression. And going back to my earlier question that I posed or I heard from many others is, well, again, why do we do this? It's part of the dementia behavior. Well, untreated agitation in dementia actually will beget even more symptoms, more behavioral symptoms, and more, negative medical outcomes. So this is a study showing that people with agitation in dementia, I'm going to try to talk over whatever we have, even is in the background.
I asked the daughter to please be.
So
John, could you please mute the audience?
So the blue
John?
bars
Thank
are
you.
people with agitation and dementia, showing that they have greater degrees of other behavioral symptoms compared to the lighter bar, which is those people without agitation and dementia. And so they had greater risk for infection, including UTIs, as well as falls and fractures. So again, agitation plus, similar to other symptoms in dementia, behavioral symptoms in dementia, if left untreated, it's just going to hasten that vicious cycle. Okay, all right. And when we look at treating dementia-related behavior, so we're probably looking at, only, primarily two modalities. And they're not necessarily, they shouldn't be mutually exclusive. They should complement each other. And so these are the non-pharmacological treatment versus the pharmacological treatment. So if we look at this graph here, so as the behavioral symptoms of a person with dementia progress, there's a decrease in quality of life. However, with non-pharmacological approaches, we can try to elevate that quality of life as much as we could. However, as the symptoms become more severe, this is when appropriate use of medications can be very appropriate to try to sustain that quality of life, not just for the patients, but also for their caregivers. But then if medications are done without much discretion, not following side effects, not monitoring side effects, using too high of a dose, then you can lead to negative outcomes and worsening the quality of life. Um, so what is known so far, evidence-based in terms of effectiveness of non-pharmacological therapy? Um, so because in a lot of settings, different institutions, they go about doing their non-pharmacological therapy a little bit differently. So the effect sizes can change, vary a lot. And the approaches are very heterogeneous, from one group to the next. But, you know, overall, there seems to be some consistent finding that for those with sort of mild depression, mild dementia with depression, that certain non-pharmacological therapies can be more effective than others. So these are sort of reminiscence therapy, which is kind of like talking about familiar objects, from your family, your past days, uh, or a group of people getting together talking about past events, past fond memories, as well as cognitive stimulation, which is usually not computer-based now, and they seem to have a greater effect, than education, physical exercise, or music. Um, However, for those with agitation, not depression, as well as those people that have sort of greater cognitive decline, physical decline, so they're not able to participate meaningfully in reminiscence therapy, for example, the music therapy has been shown to be a pretty robust alternative, evidence supported, and cost effective um, for this kind of behavior. Music, especially those that they listen to, that they're familiar with, when they're in their teens or their 20s, that type of music seems to have a greater effect than other types of music. Um, and then very recently, there's some increased evidence that massage or touch therapy can also be as effective for this, sort of more advanced type of decline. But whether how much of that is practicable, United States setting, touching people with massage, I'm just not so sure. But there's some evidence for that. But speaking of massage, when I was a medical student, I did a rotation in Thailand, and I was working in a psychiatry hospital. And when a person got agitated, I was expecting these people to get PRNs, like PRN Haldol, PRN Ativan. Guess what happened instead? They will be offered a massage session instead, but rather than chemical restraints. And they told me that the doctors over there told me that they've been pretty effective. And that kind of like related to what we know about massage therapy, having this positive effect, on a person's mood overall, regardless of the degree of your decline. Okay, so now we're going to move into pharmacological therapy. So sort of evaluating the effectiveness of pharmacological therapy with medications, it's a little bit easier because we're talking about the same medications. We're looking at the same outcomes according to the same scales. So the studies are much more homogeneous. The effect sizes are more consistent. And given that, then it's easier for us to discern what medications are more effective than others for dementia-related agitation. Um, and this is a study that's a meta-analysis that's actually very interesting. It sort of pits different types of medication and non-pharmacological interventions all in the same analyses. Um, so the ones that are circled in red are the non-pharmacological therapies. So in this case, this is a cognitive stimulation therapy versus placebo. This is discontinuation, which is getting rid of all the antipsychotics. And this is a reminiscence therapy uh, versus medications versus placebo. And among the medications, the one that seem to have the greatest effect sizes are aripiprazole, escitalopram, and risperidone. Um, and the way we want to read this is, this area to the left of the vertical line favors treatment. So the further away they are from the zero line, the more effective or the greater the effect size. Okay, and this is not a surprise because for, I would say like a decade now, we know that there's sufficient evidence to support, even though has been no FDA approved medication for agitation until recently, that antidepressants specifically, citalopram, escitalopram, um, as well as antipsychotics, especially among for those who have more physical aggression, including aripiprazole, risperidone, have been sort of used as first line for this kind of behaviors. In fact, United Kingdom and Canada had for a long time now, I think 10 years or more now, has already approved risperidone as first line agent for use of agitation in dementia. And then there are other medications. There are probably something that we may want to avoid because not only is there not a lot of evidence, there's actually some negative evidence for that. And these include mirtazapine and valproic acid or Depakote. And I'll kind of talk about mirtazapine a little bit later. And if you look at, for example, let's look at valproic acid or Depakote, which is right here. So as you can see, this is probably like one of the least effective medication versus placebo in curbing dementia-related behavior. And the whole point about medication treatment is we're trying to um, um, diminish the behavioral symptoms, without a lot of concurrent side effects, specifically concurrent sedation. Okay, so moving up to the last few years, starting from the last few years, we finally in the United States had the first ever approved medications for agitation in dementia in the form of brexpiprazole. That was 2023. And as recently as within the last 2 weeks, and this is this is fresh off fresh off the press. We have an NMDA antagonist medication with dextromethorphan plus bupropion, known as Auvelity, which is already FDA approved for treatment of depression. And as you know, dextromethorphan is a cough syrup. And we'll talk about this a little bit later. And so this is kind of exciting, but there's still limited data. But the limited data we have implies that this class of medication may have a larger effect, compared to, and not only that, they could be better tolerated too. So, and so for the next few slides, I'm going to be spending a little bit of time talking about, what we know about citalopram so far, as well as the reasons, the mechanistic reasons why brexpiprazole and dextromethorphan may make sense in dealing with, in addressing dementia-related agitation. So given that, there's different guidelines proposed, and one of the most recent guidelines is from Canada. Different types of symptom clusters in dementia, as I showed you earlier, followed by their recommended medication choices, and S denoting strong evidence, or there's good evidence supporting that. And as you can see, and unsurprisingly, citalopram is sort of the go-to, not only for agitation but for these other symptoms as well. As whereas antipsychotics can be considered for more severe agitation. And we'll talk about quetiapine a little bit later. Okay, so citalopram. So citalopram is sort of a mixture of the S enantiomers or S isomers and the R isomer, which is citalopram. And people have believed that, well, maybe the S-citalopram is primarily important for exerting its anti-anxiolytic, anti-anxiety, antidepressant effect. It's less sedating, so maybe it's the better cousin of the better brother or sister of the other R enantiomer, which is citalopram. And we'll talk about why that may or may not be pertinent in dementia-related behavior. And what we like about citalopram, S-citalopram, is they're SSRIs, selective serotonin reuptake inhibitors, and unlike other SSRIs, they have minimal inhibition of your cytochrome P450 enzymes. So unlike the older SSRIs such as Prozac, which is fluoxetine, paroxetine, which is Paxil, even sertraline, which is Zoloft. So all these medications can inhibit 2D6. So if we have our patients, especially our older patients on a long list of medications, it can cause a lot of interaction unless we have something that's a little bit cleaner, quote unquote cleaner, such as citalopram or escitalopram. And citalopram has been shown that it can be as effective for dementia agitation, even psychosis, compared to risperidone. And it's better tolerated, right? Because it's not an antipsychotic, doesn't have the nasty motor effects, side effects that you associate with risperidone with. And this is probably one of the very few cases where you can actually treat somebody with psychosis with an antidepressant, and it works as well as an antipsychotic. And this is in a dementia-related setting. Of course, if you have somebody with schizophrenia, treating the psychosis schizophrenia with the antidepressant is not going to work. And what is kind of interesting is for the last few years, there's a lot of literature about, inflammation, how if we reduce inflammation in our brain, it can have a lot of, nice outcomes. And this is what they had begun to show with antidepressants, and SSRI has been the most studied, is that antidepressants are, gradually known to be conferring some kind of anti-inflammatory properties. And there are more studies now looking at using the blood marker CRP, C-reactive protein, as a measure of inflammation, showing that with depression treatment, you can lower the CRP. And actually, those with higher CRPs, I'm sorry, that's me. I gotta turn off. Okay, my bad. Okay. So those with high CRP levels may respond to different types of antidepressants, especially when they're not non-serotonergic. So stay tuned. There's going to be a lot of exciting news about how we can, guide the choice of our medication, even in a gender-specific manner, and using inflammation as a biomarker in deciding which antidepressant and for how long and we will want to treat. But going back to dementia, the effective dose for citalopram is 30 milligrams, and it takes usually about 2 weeks for it to be effective. And what about escitalopram, which is sort of the more potent isomer of the parent compound? Well, there's a study recently showing that 15 milligrams of escitalopram, which is sort of equivalent to the 30 milligrams of the parent compound, which is citalopram, it's kind of not as effective. This is from the same people that study citalopram. It's not as effective for dementia-related agitation. And they think that the reason for that is maybe escitalopram is a little bit too potent. It's maybe not as, maybe you need that mild sedation property from the citalopram to have that good compromise. Whereas escitalopram itself is just too potent, too strong. So in my practice, when people are doing a little bit better on the escitalopram from their PCPs, but they're still a little bit agitated, a lot of times I would just switch them from escitalopram or Lexapro to citalopram, and I had pretty good results with that. Okay, and using citalopram is not all rosy. There's some side effects associated with that. And the one that I always worried about is hyponatremia. And the risk for that is, the incident could be as high as 30%, just depending on what sources you look at. But what we know is that if anyone's going to get hyponatremia from SSRI, usually happens within the 2 weeks of starting somebody on SSRI versus later on when you're trying to increase the dose. And the risk factors are people that are older, female. So our patients are like that. So routinely, if I put somebody on SSRI, I would try to check your sodium, do a BMP within 2 weeks, or I would say 2 weeks after starting the SSRI. And then the other thing that I'm not worried about too much is QT prolongation. So for citalopram, there's this government guideline that we should not try to go over 20 milligrams because of QT effects. However, that's kind of underdose, right? Remember I told you earlier that the effective dose, the average effective dose for citalopram in dementia-related behavior is 30 milligrams. So I often would go about this dosing of 20 to hit that 30, and you can see a pretty significant improvement in a lot of patients. And I think, we're probably being overly cautious, with this sort of QT prolongation warning, that only 7% with, taking citalopram will have a QT prolongation that's greater than 30 milliseconds. And usually when we look at sort of bad outcomes towards SARS or people that actually die from SSRIs, we usually looking at an overdose situation versus a clinically effective dose. Okay. All right, so we're going to move into sort of the newer medications, so brexpiprazole, which has been FDA approved. So brexpiprazole and aripiprazole, they're known as partial D2 agonists. And they're partial D2, meaning that they, bind to the D2 receptors in your, in your brain, along your nigrostriatal pathway. And if you block that completely, like risperidone and haldol, you would cause a lot of dystonia, Parkinson's-like tremor, whereas partial D2 agonists have less risk of that because it allows sort of this very low activity to continue. In the classic partial D2 agonist aripiprazole, which has all these, indications from the FDA, but it doesn't have that agitation for dementia label. But with the brexpiprazole, it does. And how is brexpiprazole different from aripiprazole, which is we're more accustomed to? Is that brexpiprazole can cause less akathisia, which is the subjective feeling of restlessness that you cannot sit still, always moving, squirming, and allegedly because it has a greater antagonism at 5C2A for those of you that are interested in receptor affinities. And also it has alpha-1 antagonism. So what it does is it sort of lowers the adrenergic levels in the CNS, so to decrease that fight or flight response. Very similar to the reason that I've seen a lot of you using prazosin, is to lower that adrenergic levels in the brain. However, compared to aripiprazole or the other medications, the data so far shows that the onset for effectiveness for brexpiprazole is not going to be as fast so it would take about 4 weeks or a little bit longer. Okay, so now we're going to move into dextromethorphan. How does a cough syrup become so important in our treatment of depression and now agitation and dementia? And and a lot of that can explain here. So this is a picture that shows different clinical effects of NMDA antagonism in our brain. And we know a lot about this primarily based on very like studies or decades of experience with ketamine. So ketamine is a psychedelic agent. It can be used as an anesthetic, and most recently it's been used for good clinical outcomes. So we know for some time that at lower doses so ketamine is a very potent NMDA antagonist. And that we know if we dose ketamine a little bit low at 0.5 milligrams per kilo intravenously, it sort of causes this rapid antidepressant effect. A specific sort of resolves someone's suicidality pretty much quickly, within a day, if not hours. And the reason for that is ketamine just forces your brain neurons, your prefrontal cortex, to start talking to one another. So if you look at neuronal connectivity in somebody with depression, that is going to be a lot less active compared to healthy controls. However,
Brett?
if we soak, yes.
Brett, I'm so sorry. Your slides don't show anymore.
Oh, you are sharing screen. For how long has it not been showing? Okay, I'm gonna stop sharing. I'm gonna start again. What about now? Can you see?
Okay, now it's there. Thank you.
Oh, okay. Were you able to see the previous ones?
Yes, thank you.
Okay. All right. So at higher doses of ketamine, there's an anesthetic effect. And then, and it can be abused. It's a rare medication, so it has psychedelic effects, even higher complete dissociation. So now at the other end of the spectrum, we have lower doses. About 10 years ago, a new medication came out known as Neodexta, which combines dextromethorphan, which in itself is a potent NMD antagonist, not as potent as ketamine. It can help decreasing pseudobulbar affect, which describes uncontrollable crying and laughter, especially in those with dementia, stroke, or with autoimmune illnesses like multiple sclerosis or lupus. And however, at even higher doses, people have shown that dextromethorphan can start exerting antidepressant-like effects, almost similar to your intravenous ketamine. And recently it's been approved for agitation in dementia. So now the question is, why are these medications or bupropion, quinidine tethered to the dextromethorphan? Why is it like that? Well, it all boils down to how dextromethorphan is metabolized. So as you're aware, cough syrup, dextromethorphan, is a drug that can be easy to abuse. That's why it's sort of restricted for minors. And the reason for that is dextromethorphan is broken down rapidly by our liver cytochrome P50 enzyme 2D6 into dextrorphan, which is its main metabolite. Dextrorphan is a lot more potent of an NMD antagonist, even 15 times more potent than dextromethorphan. And this is where people get their craving, for the psychedelic effects. And that's why these medications, that dextromethorphan is compounded with quinidine or bupropion, and these medications are known to block or to inhibit the conversion of dextromethorphan to dextrorphan by 2D6. All right, so then we can keep a healthy level of dextromethorphan as much as possible. So what's good about dextromethorphan, this cough syrup? Well, it has some serotonin blockades, kind of like a classic SSRIs. And we talked about NMD antagonism also can lead to rapid antidepressant effect. However, what's the most exciting about dextromethorphan is that it's one of the few medications that has a very strong sigma-1 receptor agonist activity. Which offers, which helps, which offers it, as a good antitussive, anti-cough, antidepressant. But the most exciting aspect is sigma-1 receptor agonist activity has been correlated with anti-inflammatory, anti-apoptosis in our brain. So it sort of maintains and restores and decrease all the inflammation. And there's actually an accidental finding during COVID that of people taking fluvoxamine, which is an SSRI with a very strong sigma-1 agonist activity. People taking fluvoxamine, when they're afflicted with COVID, they're less likely to be hospitalized versus those without fluvoxamine. And they think primarily because fluvoxamine helps to dampen that unnecessary inflammatory response from the COVID virus. Yeah. And kind of like that, and similar to what we've seen with antidepressant effects, the onset of action in agitation for dementia and depression is pretty fast, it's pretty rapid, taking a week only, as opposed to 2 weeks for citalopram, risperidone, and 4 weeks for brexpiprazole. Okay. All right, and for Lewy body dementia, this is where it seems to be the second most common dementia now after vascular. And the reason I want to bring this up is this is where the psychosis, which can be seen a lot early in the progression, as opposed to Parkinsonism, which is seen later than the visual hallucinations. This is where, if you're not sure whether your patient has Lewy body dementia or not, one of the signs could be that, well, if they're not responding to your typical antipsychotics or risperidone or aripiprazole, which blocks the D2, this is when you might want to consider switching gears. Maybe you're looking at undiagnosed Lewy body dementia. You want to consider using medications that like quetiapine, which is antipsychotics that can be pertinent, appropriate for use of psychosis or agitation in Lewy body dementia. And there's some evidence for rivastigmine, and we don't use clozapine. It requires too much blood monitoring. And if quetiapine doesn't work, there's FDA-approved psychosis for Parkinson's disease medication in the form of pimavanserin. Okay. All right. So I'll just kind of talk a little bit about mirtazapine. It's a very potent antidepressant, so it increases norepinephrine in our brain. But in a person with dementia that's already agitated, you probably don't want that increased norepinephrine in your brain because it can lead to negative outcomes. And this is what this study has shown. However, if you have a person that's not agitated, maybe with some dementia, they're depressed, they have trouble sleeping, poor appetite, mirtazapine can still be a good choice. And then I want to talk about this paradoxical effect. I have enough residents and medical students trying to impress me. Dr. Liu, did you know that I heard from so-and-so that mirtazapine is more studied in lower doses because it's more antihistamine-like and it's higher dose and it's more activating in higher doses because of the increased norepinephrine and serotonin activity. Well, where's the evidence, right? Because this is an evidence-based talk. And so far, there's no evidence. It's sort of neat how it may make sense, but the evidence is contrary to that. There's no evidence to show that there's a dose-related decrease in sedation with mirtazapine. Okay, so this is going to summarize the first half of my talk today. And if we sort of array the medication we talked about according to their benefit versus risk ratio, we obviously want medications with high benefit, low risks. And this is where traditionally we've been using the citalopram and the antipsychotics listed right here. And who knows where the dextromethorphan is going to take us. It may be one of those nice, promised medication that's going to be even more effective and safe than the ones that we're using, that we have available, but cost may be a concern going forward. Okay. All right, so we're going to jump into the second part of my talk, which is a lot shorter than the first part, which is kind of looking at depression in a primary care setting. So as we get older, the depression rates increase until we're 60. After that, it starts to decrease. But it doesn't mean this is just going to go away. And females are more likely to have depression, as shown by the green bar here, in older females as opposed to older males. However, when we look at successful suicide rates, males have a lot higher, older males especially have a lot higher successful suicide rates compared to females. So how is this pertinent to us? Well, when do these suicide rates increase? Often in the setting when within the time that they're told that they have a dementia diagnosis, within that first month, especially those with concurrent mental illness. And however, the suicide rates do decline once they're placed. I guess because they're more supervised, there's a greater level of mental stimulation, thereby that lead to the decrease in suicide rates. Okay, and how do we detect depression in older people that may or may not have dementia? As we talked about earlier, they're irritable. They're associated with reporting more memory problems, more somatic complaints, and more problem with their sleep. So these are some of the sort of the subtle signs that you may be looking at a person with depression in older age. Even if they're not able to tell you, they're guarded about telling you whether they're depressed or not. Okay. And one population that we want to be worried about are the caregivers. So if you remember, we talk about 5% of the dementia patients, 5% of the general population with depression at any given time. That rate skyrockets to 32% of depression among people that are full-time dementia caregivers. So when I evaluate people with dementia, I tell the caregivers, I'm worried about you as much as I'm worried about the patient, and this is where you have to make sure you take care of yourself more before you can start taking care of others. Okay. Okay, so are antidepressants inherently bad? Okay, so thanks to um, ChatGPT, whatever, or latest government directives about de-prescribing. Um, I have patients and family ask me all the time, what's the point of using antidepressants if they're associated with memory decline and falls? And even the authority on geriatric medicine prescription Beers criteria say we should avoid SSRIs in those with fall risk. But it does admit that the evidence is weak. But conversely, having depression itself will increase memory decline, as we talked about. It also increase the rate of falls. So how do we kind of make heads and tails out of this? And this is what I call a sort of a classic confound by indication, where uh, people with depression um, themselves will have higher risk for falls and memory risk, for falls and memory decline compared to healthy controls, right? So if you treat the people with treat people with depression, if you treat depression people with antidepressants, of course, if you look at people taking antidepressants, they're going to have higher rates of memory decline and falls compared to healthy controls. So then the more exact question is whether the use of antidepressants will move the risk down or low, higher, lower or higher. And the evidence so far show that use of antidepressants among those with depression actually decrease the memory risk, the memory decline as well as falls. So this is a meta-analysis done that show that cognition does improve with antidepressant treatment among those with depression in a phenomenon we call pseudo dementia. Okay. What about falls? So this is one of those nicely designed studies looking at only those people that are older with depression over 6 months and looking at whether use of antidepressants is associated with higher or less falls compared to controls. And the studies show that people using antidepressants for their depression actually have less falls, within the first 6 months compared to no treatment or psychotherapy. And applies to pretty much all the antidepressants tested. Okay, so now we're getting to the last part of the talk, which is, in sort of everyday conversation, counseling of our patients, what can they do on their own to decrease that, memory-related risks, to decrease our risk for dementia? So this is a very recent Lancet commission that looked at all the modifiable risk factors. And they had listed 14 pillars of tried and true modifiable risk factors, baked, by hard science, that we should all be aware of, in talking to our patients. And they're listed right here. And with depression over here too, separated by, stages of life. And what is interesting is they also give you sort of this estimates of the rates that you could decrease, the risk of dementia in terms of degrees. So for example, if somebody address all these lifestyle modifications, all 14 of them, you can potentially decrease your risk of dementia by close to 50%, as noted right here. And the effect sizes do vary from one risk factor to the next. And the highest being, if you don't treat your hearing loss in midlife, that's like the highest known risk for later acquisition of dementia. Okay, and what about the pathogenesis? Again, it usually involves neuronal inflammation, accumulation of proteins, amyloid beta, tau proteins. And so mechanistically also makes sense. But then there are some risk factors that almost made the list, close but didn't. So these are sleep, diet, such as the Mediterranean diet, or other mental illnesses. So if you're untreated bipolar, untreated schizophrenia, your risk for memory decline, your risk for dementia are actually going to be greater. And as well as hormonal replacement therapy for postmenopausal women. Okay, um, so I'm going to talk about sleep a little bit because it's such a commonly encountered complaint. You know, when we talk to our older patients. Okay, so this is sort of sleep architecture here, um, from awake to REM sleep to non-REM sleep. Um, and what we consider the most restorative sleep or deep sleep is REM 3, non-REM 3. However, as we get older, our sleep architecture is a lot more fragmented. We spend a lot more time awake, you know, being awake, and we don't have as much slow wave sleep. Um, so it takes us longer to fall asleep as we get older, um, and um, and it will decrease lymphatic flow. I just gave grand rounds recently on lymphatic flow, which is sort of the system your brain has in having all these channels accompanying the arterioles and the venules, you know, into the deep parts of your brain that help to flush out all the toxins that can cause inflammation in the brain. And the lymphatic flows primarily occurs when a person is in deep stage sleep. Um, so and more so in non-REM 3, a lot more so than other stages. Um, and why is it pertinent? Even though it's not one of those 14 pillars of modifiable risk factors for dementia, um, we have, you know, studies have shown that sleep disturbances can increase the risk of dementia as well as biomarkers. And for somebody that don't sleep, um, that don't sleep much or 7 hours or less, their mortality does increase by 14%. But on the other extreme, on the other hand, if you somebody who's sleeping too much, they think probably related to just, you know, increased medical burden. There's even a higher risk for mortality. Okay, so this is just a glimpse of the lymphatic system, you know, with your exercise forming this sheet of channels, allowing you know, your CNS or the cerebral spinal fluid, the CSF, to flush out all the toxins driven by these arterial pulses, you know, by the norepinephrine. So that's what we're going to talk about today for this. Um, and and it's kind of exciting because we didn't know much about this system, which is sort of analogous to lymphatic system in the peripheral part of our body until like 10 years ago. So how do we optimize sleep? So I'm not going to go into cognitive behavioral therapy for sleep or CBTI, but things that we can do is to avoid alcohol. Alcohol does cause early awakening, and it reduces slow wave sleep. And that's remember, slow wave sleep is when we want the lymphatic flow to exert its optimal function. Um, what about medications? So benzodiazepines, hypnotics like Ambien or Zolpidem, they either they suppress slow wave sleep or they decrease that pulsation in the arterioles that's needed to cause that hydrostatic pressure to flush the toxins out of your brain. So you may have some short-term benefits, you know, with these things, but long-term, um, it's going to be deleterious because it's going to suppress the slow wave sleep. Um, and there's some medications that can help to enhance slow wave sleep, you know, which sometimes I recommend. Um, okay. Um, and the last part of our talk is, um, so in terms of sleep medications, you know, if they don't respond to CBTI or cognitive behavioral therapy for sleep, are there sleep medication classes that can preserve the sleep architecture, right? Please preserve the amount that whatever little amount of time we already have as we get older in slow wave sleep, and not causing a lot of side effects. And this is where kind of orexin comes into the spotlight. So orexin, if you think about it, it's sort of the opposite of melatonin. So orexin is a neuropeptide that we need to keep ourselves awake. So as you see, orexin levels are highest during the day. It dips at night, and whereas melatonin has totally the opposite curve. And lacking orexin means that it's hard for you to stay awake, like people with narcolepsy. And 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 then if you try to have too much orexin level, not only does it impair sleep, it actually forces, it also causes more amyloid beta, phosphorylated tau to be accumulated, presumably because you're not getting that lymphatic flow, in deep sleep to flush out the system, to flush out your toxins. Um, and orexin, and these, so that's why this newer class of medications known as dual orexin receptor antagonists, or DORAs, can be effective, unlike other sleep agents we have, in sort of preserving that slow wave sleep. In addition, there's studies showing that in mice and in humans, that these DORAs can also help to clear the beta amyloids, as well as the phosphorylated tau. So it has that additional benefit. Okay, so mechanistically, if it makes sense for the DORAs to preserve sleep architecture, but how effective is it clinically? And the data so far shows that it's kind of impressive so far. So these are the 3 DORAs that are available to us: suvorexin, lemorexin, daridorexin. And they seem to be pretty well tolerated. And not only are they effective for sleep latency, which is help a person to sleep faster, they're also effective for a person to have their sleep maintained, so sleep maintenance. So this is a chart shows different FDA-approved medication options for sleep onset, sleep maintenance, as well as abuse potential. And DORAs is the one that sort of checks all the boxes in being effective for sleep onset, maintenance with minimal abuse potential. And this is another meta-analysis showing that this class of medication is effective, in terms of compared to other antidepressants, compared to other sleep medication classes. So the last thing I want to talk about is melatonin. So we talked about orexin versus melatonin, sort of this dyad. And we talked about how DORAs can decrease orexin level. What about trying to boost the melatonin? Does boosting melatonin, can that be as effective in promoting sleep as decreasing our orexin levels? Well, probably not as much, but it does have some effect. And this is where people try melatonin agonist, in forms of melatonin over the counter, or Romeltian, which is the melatonin agonist. And these medications can help a person sleep faster, but unlike the DORAs, they do not have much effect on maintaining a person to allowing them to sleep longer. And I've seen a vast variety of how different people use over-the-counter melatonins. People ask me like, "What, Dr. Liu, I want to use 50 milligrams of melatonin. I'm going to use melatonin's PRN for agitation." Well, and this is what the studies have shown so far. So this is a meta-analysis that was done recently, showing that the total sleep time does increase as you increase the melatonin dose, but only up to a certain point. So once you hit about the 3 or 4 milligram mark, any more melatonin dose is not going to be any more effective, if not having a negative effect. And this is sort of not surprising, because when they did the studies, they actually show that you only need as little as 0.1 milligrams of melatonin to simulate that physiological peak that we get, as part of the melatonin surge at night. So more is not going to be merrier. And what's the best time to dose melatonin? And so if you give melatonin right at sleep, the data is not as effective versus giving melatonin earlier in the night. So, with this nice decreasing slope, which is, if you give it earlier, if you give, 2 hours before sleep, then the sleep latency onset, which is how fast it takes for you to fall asleep, is actually improves. So the sweet spot of giving somebody melatonin is probably going to be 1.5 to 2.5 hours before sleep, which is usually, maybe, I would just tell them after dinner time, just pop in your melatonin at doses not greater than 5. Okay, so I think that's what I want to talk about today. Thanks for your attention. I'm going to stop sharing and I'm going to entertain questions.
Brett, thank you so much for a wonderful presentation. I see one question in the chat already. Jody, would you like to unmute yourself and ask your question?
Thank you. Yes, Dr. Liu. A
Hi,
couple
Jody.
questions, actually. I had a friend who was getting treated with radiation for prostate cancer, and he was taking melatonin to help him sleep. He's in remission now.
Okay.
And he had a very troubling occurrence of sleepwalking where he didn't remember, and he found himself on the floor in his closet. He had fallen on the floor and he didn't remember anything.
Okay.
And he contacted me thinking I might know something. All I did was Google it, and I saw that melatonin can sometimes cause sleepwalking and possible hallucinations. Have you
Yes.
heard about that?
Yes, I heard of that. And also sedation the next day. So I don't know if there's well-known risk factors for these types of melatonin-induced horrible dreams or even psychosis. But the rule of thumb is when we use melatonin, go very low and slow and no higher than 5 milligrams. So I don't know how much he was using. Um, so that would be one consideration. And and if he's using 3 milligrams or 5 milligrams, it's not working, it's causing all these side effects, I would say just move on and try something else. The only times that we want to use high doses of melatonin uh, would be in people with REM sleep disorders. So this is when they act out in their sleep, they're talking out loud, they're thrashing about, moving their arms and legs. Those are the very few incidences where higher dose of melatonin, 10 milligrams or higher, may be effective to suppress the REM behavior.
Thank you.
Thank you, Brett. Oh, Marina, would you like to unmute and ask your question?
Hi, sorry if it's too, can you hear me?
Yeah, I can hear you.
Yes.
Okay, sorry if it's too specific of a question because this just came across
Okay.
my clinic today. I have a lady with dementia. She's already on, I actually did the switch from escitalopram to citalopram. She's got a
Okay.
lot of
Oh,
restlessness.
she should be giving this
She's
talk.
she's she's been on trazodone like 100 plus 50 PRN. They're giving the PRN every night, but she's still up like 3 to 7 times a night. So I was wondering about thoughts of like adding doxepin versus switching to doxepin.
Yeah, so
Because I don't know if the door is going to get covered for her.
yeah, I agree. So I didn't have time to cover like all. I mean that's a talk in itself. The sleep medications, if I ever get invited back. But anyway, so yes, antihistamines are much more effective for sleep maintenance. So antihistamines would be the doxepin, um, hydroxyzine, Benadryl, which is diphenhydramine. So you can look into that, but not all antihistamines are created the same, right? So as you know, some antihistamines are highly anticholinergic, some others aren't. So at low doses, doxepin is safe, minimal anticholinergic property. Probably anything 20 milligrams or less will be okay. And then so same with hydroxyzine. Hydroxyzine has a bad rep, and you can see in my slide that I didn't get a chance to show you, because it's listed as something that's highly anticholinergic on the Beers criteria, but it's not. If you look at the studies, it's just guilt by association. It's one of the first generation antihistamines that have very low anticholinergic property. So I think between doxepin or hydroxyzine, I probably would use doxepin because it's better studied for insomnia, for your lady with a sleep maintenance issue. Um, so in terms of cost, yes, the DORAs are still can be kind of costly. So I would say sort of the three top choices probably would be, the melatonin if it helps, some low dose trazodone to help with the sleep latency, and maybe some doxepin for the sleep maintenance. So these are probably the three most cost effective and safer medication options for older individuals.
Thank you so much. Any other questions? We have time for maybe one last question. Lauren is asking about the PowerPoint. Lauren, this has been video recorded, so it will be put on our website in a few days.
And I think I had given you guys a copy of my slide, and you had my permission to turn it into a PDF for distribution.
Oh, thank you so much, Brett. That's wonderful. So again, please join me in thanking Dr. Liu for a wonderful presentation. John has put the link to the evaluations in the chat. Please remember, if you want to get CME credits, you do need to complete an evaluation. Brett, I want to thank you again for doing a wonderful grand rounds. We've had a record attendance again today, which just shows you're a very popular speaker. We will definitely be inviting you again to come and talk to us.
Thank you. I enjoyed it. Thank you, Kamal.
Thank you so much.
Okay. All right. Okay. Bye-bye.